Hello, everyone, and welcome. Thank you so much for joining us today. I'm sure people will continue to join, but we have a lot to cover, so we're going to dive right in. My name is Lynn Van Lith, and I'm the Technical Director for Breakthrough Action. It is my absolute pleasure to welcome all of you and introduce our amazing speakers today. During this 1-hour webinar, we're going to share the results of a randomized controlled trial of the cognitive behavioral therapy tool called Mother's Time that was recently tested in Ethiopia among postpartum women with mild to moderate anxiety and depression. And the results have really shown promising evidence for the use of cognitive behavioral therapy tools to improve postpartum mental health and support women in low resource settings to realize their reproductive health intentions. So as we're kicking off, as you can see on the slide, please, we welcome you to introduce yourself in the chat with your name and affiliation. And yeah, please go ahead and enter that in the chat and we'll move to the next slide. I wanted to just share a very, very brief overview of the Breakthrough Action Project. We are an 8-year cooperative agreement funded by USAID. The partnership is led by Johns Hopkins Center for Communication Programs, the institution that I work with, along with Save the Children, Think Place, Ideas 42, Canberra Collective, and the International Center for Research on Women and VIAMO. So our 3 amazing speakers today are on the slide. First is Zoe Hendrickson. She has served as the principal investigator for the study and has been an associate professor of public health practice at the Johns Hopkins School of Public Health and is now at the University of Pittsburgh School of Public Health. Tessera Bita is an associate professor of mental health epidemiology at the Injambara University. And the amazing Leah Holmes Mallet is an associate consultant. She's with Canberra Collective and has been absolutely instrumental in carrying out this study. So they will each take turns kind of going through the presentation. We also absolutely want to acknowledge and appreciate the many other people who are involved in this effort, including colleagues from the Ministry of Health and many, many more. And we'll touch on those acknowledgements later on in the presentation. So with that, and again, please continue introducing yourselves in the chat. You'll notice there is also a Q&A function on the Zoom call here. So please, if you have questions at any time, we will be taking those in the Q&A box. So please enter them there. We'll be tracking them. And then Jessica from Canberra Collective, who has been intimately involved in this effort as well, will be answering as many questions as possible in a written form. And then we'll have time for each of our speakers to actually address you all and answer some of those questions as well. So please feel free to use the Q&A chat throughout. And with that, I will pass to Leah to take it away.
Thank you, Lynn, for that fabulous introduction, and hello, everyone. So before we jump into the presentation, we wanted to set the stage with some data around the impact of mental health on family planning in low and middle income countries. So on the screen, you should see 2 poll questions pop up. The first poll question is related to the burden of disease for common mental disorders in low and middle income countries. And the second is related to unmet family planning needs postpartum. So we'll give you all a moment to respond, and then we'll share the results and continue with the presentation. All right, it looks like we have most responses. If we want to share the results. Great, thank you. Okay, so it's looking like everyone is saying that in terms of how many women in low and middle income countries experience common mental disorders, everyone's saying around 1 in 5. And then we have a spread on this next question, which is how many postpartum women in low and middle income countries have an unmet need for family planning? Across the board, people are saying 1 in 5, 1 in 3, and a little bit less are saying 1 in 2. So on this next slide, here's the answers. So in low and middle income countries, we're seeing that the prevalence of common mental disorders is around 1 in 3, around 33%. And then about 50% of women who are 1 year postpartum have an unmet family planning need. So across low and middle income countries, we're seeing that many postpartum women have this unmet need for family planning, but they also experience depression and anxiety. So these two challenges are really intersecting for a lot of mothers. And then in Ethiopia, this follows similar trends. So postpartum depression is around 23% in Ethiopia. And then when we look at modern family planning use postpartum, it's around 25%. And then despite this data that's showing the intersections between a mother's mental health and her family planning needs, mental health is rarely integrated or considered in family planning or maternal health service delivery. This can be for several reasons. I'll touch on those in a moment, but there's also a lot of substantial evidence that supports the negative impact of mental health challenges on a range of health behaviors. So we see mental health really impacting postpartum health behavior, infant health and nutrition, comorbidity for other illnesses like malaria and people living with HIV/AIDS, as well as family planning. Specifically around family planning, this relationship can be seen as bidirectional. So unintended pregnancies can put women at greater risk for developing perinatal and postpartum depression, but also symptoms of depression and anxiety can adversely affect sexual and reproductive health, which includes contraceptive use and sexual risk behavior. However, this relationship really is less explored compared to some of these other areas listed on the slides. And then one additional point on this slide is related to the burden of disease. So in calculating burden of disease for mental health, it does not often consider these confounding effects that mental health might have on other health areas. So the burden is likely very underestimated. And then there are several reasons why mental health programming might not be integrated into existing family planning or MNCH programs. So while this slide is not a comprehensive list, some of the key reasons include staffing shortages or burnout or time pressures that might affect providers' capacity to deliver services. There's also limited financial support for mental health services. They're typically underfunded compared to other health conditions. In terms of care seeking, there's stigmatization that a lot of patients will experience, and women who suffer from mental health challenges are often faced with shame, guilt, and reduced quality of care. There's also gender norms that might mediate some of these effects. So lack of autonomy, financial independence also pose barriers to people who are seeking care for family planning or experiencing mental health issues. And then in terms of contextualization, these challenges can vary based on context. And so there's a need to tailor interventions to address these specific norms across contexts, and this requires additional work, which makes it challenging to scale across contexts sometimes. So with that, I'll turn it over to Sarah, who's going to share some details on the intervention, including the process that we used to address some of these contextual barriers in Ethiopia specifically. So to Sarah, over to you.
Okay, thank you so much, Leah. Yeah, in low-income countries, particularly in Ethiopia, there is a need to adapt and develop mental health interventions. Cognitive behavioral therapy, CBT, is one evidence-based practice helpful for changing behavior across several healthcare. Anxiety and depression, or what are known as common mental disorders, are very prevalent. As we have seen, they affect 1 in 3 women. And they are very, very dysfunctioning, affecting impairment of women in caring their kids, as well as caring their selves, as well as the family. So intervention is always essential. In Ethiopia, moderate and severe health conditions, mental health conditions, are treated nowadays in tertiary hospitals, but attention is not given for mild symptoms, which are very disabling and which can be treated, however, by such psychological treatment modalities. So CBT is one of the modalities that assumes that thoughts always affect our emotions and behaviors. Whenever we have negative thoughts and productive thoughts, we would have unproductive or unhealthy emotions and feelings, and these feelings ultimately affect our actions and behaviors. And this is the basic modality of cognitive behavioral therapy. And this cognitive behavioral therapy is evidence-based therapy that is developed by WHO nowadays, being functioned in healthcare systems. It is promising approach to reduce anxiety and depression, and even some somatoform problems. Next slide, please. Yeah. So taking this in mind, CBT, we have adapted CBT in Ethiopia, and we have termed it as thinking. It has been called thinking as in Pakistan, after it has been adapted from the original CBT. And nowadays, the WHO has received thinking healthy as evidence-based intervention for common mental disorders. And we adapted this thinking healthy for Ethiopian context, and it has been called mother's time intervention. This mother's time intervention is supposed adapted for women having depression and postpartum depression and anxiety. So breakthrough action with Ethiopian mental health experts developed mother's time for Ethiopian community health workers. Community healthcare workers in Ethiopia are known as health extension workers, which is synonymous term, to use with postpartum women experiencing mild to moderate symptoms of depression and anxiety. The mother's time intervention has been pilot tested and refined based on feasibility study. Each session took about an hour and a half, delivered to small group of 4 to 6 women, and in each session there was homework delivered to women. So the 4 sessions, in the first session it targets on providing common ground about what healthy thoughts are, because the healthy thoughts affect, as you say, about the emotions and the behaviors of women. In the second section, we were targeting on thinking healthy about themselves, about oneself by the woman. In the third session, it targets about relationship, thinking healthy about relationship, and finally, it targets on thinking healthy about the family, which targets on family planning generally. In doing so, we had a model, a character called Brahan, which was initiator. We used Brahan along with the pictures and with feelings and emotions and thoughts described below the pictures, so that it can initiate discussion for women in groups. Then they were given homework, and after first session and second in next sessions, women were given homework, and they were followed up whether they were doing homework, and they were assisted with the homework, and this homework gave the women the opportunity to practice what they have discussed in groups during the in each of the interventions. I mean, in each of the sessions. I mean, thank you. This is all for my side. I will hand it over to Zoe. Thank you so much.
Great. Thank you so much to Sarah for that fabulous overview of the intervention. So building on the pilot testing and the feasibility and acceptability study that Sarah mentioned, we wanted to get a better understanding of what were the effects of the intervention on some of those key outcomes we were interested in. And so to do this, we implemented a cluster randomized controlled trial to examine both the short, immediate effects of the intervention, as well as some of the longer term effects of mother's time. So to do this, the study had two arms, an intervention arm and a control arm. And folks in the control arm were offered the standard of care with the option to participate in the intervention if further along in the evaluation it was deemed effective. So we chose this design for a lot of different reasons. First, because of feasibility. Second, because of the reduced risk of contamination across study arms because of that cluster design. And then finally, the fact that the research team was able to evaluate the effects of the intervention really without disrupting the routine community health service delivery that was happening at the local level. And so as you can see on the left here, the objectives of this study were first to look both at the intermediate and longer term effects of the intervention on three primary outcomes. First, some of those behavioral predictors of family planning, those intermediate factors that we know are associated with some family planning behaviors. So this includes things like reproductive agency, intention to use a family planning method, self-efficacy, as well as partner communication. Second, we also wanted to look at effects on mental health outcomes, things like symptoms of stress, depression, and anxiety in particular. And then finally, we were interested in looking at the effects of the intervention on use of a modern contraceptive method and decision-making around pregnancy prevention. So as you can see on the bottom left of the slide here, we administered quantitative structured questionnaires at 3 time points. So first at baseline just before the intervention, then just after, immediately after the intervention, which we'll talk about in the presentation today as N-line. And then third at follow-up, so 4 months post-intervention. So looking at some of those longer term effects of the intervention. Now, the study was implemented in the Amhara region, in the West Gojam zone in particular, and we purposefully sampled 4 worredas within that area that are shown in this map here. And so because this is a cluster randomized controlled trial, within those 4 worredas, we identified 10 health centers, which were what we used as the clusters, that were then randomized to either the intervention arm or the control arm for the study. So 5 clusters in each arm. Now, each health center had about 5 kebeles, which is an administrative unit within Ethiopia. It sort of ranged from 3 to 7, but on average, there were about 5 in each health cluster, in each health center. And so within each kebele, so there's sort of a nesting effect here, there were 2 health extension workers who were responsible for the implementation of mother's time in that intervention group, who received training for how to implement it. Now, eligibility for folks to participate in this study was being between the ages of 16 and 24 years of age, not currently using a method of modern contraception at baseline, having mild to moderate symptoms of anxiety and depression. And this was based on a screening tool that used GAD-7 for anxiety symptoms and the PHQ-9 questionnaire for depression symptoms. And then finally, the last eligibility criterion was that they had to have given birth within the last year. Now, folks who had those more severe symptoms, either of anxiety and depression based on the screening, were deemed not eligible, but they were referred for services. Next slide. This slide outlines the theory of change for the intervention, and I want to call your attention to a couple of different things on this slide. First, if you look on the left here, it outlines the fact that this intervention, just as Sarah outlined, was multi-pronged. So it was designed to support participants in addressing thoughts relevant to family planning, fostering peer interaction, using journaling to promote self-compassion and reflection, and finally, fostering linkages with the community health system. Now, this intervention was hypothesized to do three things: to address mental health symptoms, to enhance informed decision-making related to family planning, and ultimately to facilitate uptake of modern family planning. And so as you can see on this slide, the key outcomes of interest for this study included changes to those mental health symptoms, particularly anxiety and depression, as well as modern family planning use. And then in the middle there, under that family planning behavior change bucket, we also had some secondary outcomes that we thought of as intermediate factors along that theory of change. Those things were self-efficacy, partner communication, intention to use a family planning method, among others. And so we looked at those things to test some of the hypotheses that we had along that theory of change. Next slide. So before we dive into the exciting results of this intervention and the evaluation, we wanted to provide just a brief overview of some of the data collection details as well as the analytical approach that we used. So on the left, thinking about data collection, the research assistants that were central to the implementation, the successful implementation of this study, were from West Gojam, where the study was conducted. The surveys that were used included a variety of different questions, different domains, including sociodemographic characteristics, factors related to mental health, factors related to family planning, as well as those intermediate factors along the theory of change that I've talked about so far. Now, training for the research assistants that were central to this study took place over 4 days and included a number of different things, from research ethics to an orientation of all of the different steps of the process, to looking at the survey procedures and tools. But most importantly that I want to mention is the focus on mental health training for those research assistants to make sure that they were comfortable and qualified to administer the screening process, those GAD-7 and PHQ-9 questions, as well as how to make referrals if necessary during implementation. Now, on the right, we also wanted to spotlight some of our analytical approaches. And the analysis for this study really included 2 specific things. First, a cluster level analysis, and then second, an individual level analysis. For those of you familiar with cluster randomized control trials, it's important to recognize that individuals within a particular cluster, which is how you recruit individuals, tend to be more similar than individuals from a different cluster. And that's something you have to account for in how you analyze the data. So to do this, we sort of took 2 primary approaches. Given the number of clusters that we had in our study, it is a relatively small cluster randomized control trial, and the fact that some of our clusters were different sizes. Remember, I mentioned that some had as few as 3 kebeles, some had as many as 7. The first and primary approach that we took was a cluster level analysis. And so what this means is that we looked at those primary and secondary outcomes from mental health symptoms all the way through to use of family planning at the cluster level, so at each of those 10 clusters. And then we looked at overall the mean of those clusters. So we looked at those cluster means at baseline, at end line, so immediately after the intervention, and then also at follow-up. And then we also wanted to look at changes over time. So we looked at the changes in those cluster means or cluster proportions from baseline to end line or baseline to follow-up to see what had changed over time. And we also wanted to compare intervention and control. Now, the second approach to analyzing data using a cluster randomized control trial is what's called an individual level analysis. And so in this approach, rather than presenting those cluster level findings, instead you present results, something like an odds ratio that folks might be familiar with, for the effect of the intervention on an individual. Now, to account for clustering, we ran individual level models using multi-level mixed effects models to examine the differences between intervention and control arms over time. The results that we will talk about over the next few slides are from primarily that cluster level analysis, but we do want to emphasize that the findings from the individual level analysis are consistent with those presented here. Now, we don't have enough time to talk through all of the methodological details. As a researcher, I wish we had all the time in the world. So if you have further detailed questions about that, feel free to pop those into the Q&A, and we'll attempt to answer all of those at the end of the presentation. So as we dive into the results, there are a few things we want you all to be thinking about and considering in terms of implications. First, thinking about the potential for integration of this work into community health programs. Second, the potential for scale and the use of digital innovations to help with that scaling. And then finally, is there relevance for these findings and of this intervention for health areas beyond family planning? So with that in mind, we are now going to dig into some of the exciting results of this study. What we'll do first is look at the mental health outcomes, primarily anxiety and depression. So you'll see on this screen here 2 figures, and each figure shows the average cluster mean score of either GAD-7, so those anxiety symptoms on the left, or depression symptoms based on the PHQ-9 score on the right. And what each figure shows is the average cluster mean of those scores for the intervention group, so that darker blue, and the control group, looking at baseline, end line, and then follow-up, so across the 3 time points. And so a few points to mention here. First, when looking at anxiety symptoms, you'll notice that the clusters in the intervention group had significant reductions in anxiety symptoms from baseline to end line, and also from baseline to follow-up. And this was in comparison to the control clusters. And you can notice this because that intervention line really drops quite distinctly compared to the control line and really stays lower even across the 3 time points. Now, if we move to the depression symptoms, we can see that there were reductions in depression symptoms actually for both study arms, from baseline to end line and then to follow-up. But we start to see from baseline to follow-up, that 4-month time period, that it's only there where the reductions become significantly different for the intervention and the control. And so you see at time point 2 at end line, the control group starts to level off. It's not as steep of a decline. But in the intervention group, those symptoms continue to reduce significantly. Next slide. So those were the results related to mental health outcomes. The second piece that we want to talk about is some of those intermediate factors that affect family planning behaviors. And so here we're digging into 2 of those particular factors. On the left, partner communication about family planning, and then on the right, reproductive agency, which we've defined as having the final say regarding pregnancy prevention. And here you'll see that this shows the cluster proportion in the intervention group and in the control group of reporting partner communication at baseline, end line, and follow-up, or of reporting reproductive agency at baseline, end line, and follow-up. And what's particularly interesting here is that the clusters in the intervention group have significant increases in both partner communication as well as reproductive agency when going from baseline to end line. However, that difference is not sustained when we get to 4 months after the intervention, where the intervention group really comes back and meets the control group. So this lack of significant sustained change from end line to follow-up had us asking some questions, and we have a lot of different hypotheses related to this. One that we would like to explore further is that this may be due to the fact that at that change that's significant from baseline to immediately after the intervention may mean that those discussions and decisions took place and led to action. And then once that action happened at end line, that discussion and those decisions did not happen again from end line to follow-up. And this is something we would like to explore further in the data. Next slide. And so finally, we come to the last piece, which is looking at modern family planning use, as well as intention to use a family planning method in the future. And so we can see on the left, the percentage using a modern family planning method. And what's particularly interesting here is that everyone starts at 0. Remember, an important eligibility criteria was that no one was using a modern contraceptive method at baseline. And from baseline to immediately after the intervention, there really is no significant difference between the two study arms. But where we start to see that significant difference is when we look 4 months post-intervention, where we see that the intervention group greatly increases to 77% average cluster proportion reporting modern contraceptive use compared to 59%. And this is a statistically significant change from baseline. However, on the right, you can see that in terms of intentions, there were no significant associations between intervention arm and intention to use. You can see really intention to use across study arms is relatively high from baseline to end line to follow-up. However, you can see if you dive in and look in the follow-up in particular, 4 months post-intervention, that a large percentage of those in the intervention group that had intentions to use a family planning method acted upon those intentions to use a method at follow-up. So there are a couple of interpretations, and we have a few hypotheses for why we're not seeing those significant differences in intention. First, it may be that intention is not the best construct to be looking at. Instead, that those constructs related actually focused on contraceptive behaviors, such as use of a contraceptive method, are more useful. Second, intention was quite high across the board. And so it may just have been that there was not as much room to move from baseline to end line. However, we are seeing that significant uptake of a modern contraceptive method at 4 months post-intervention. Next slide. So to wrap up, we just want to provide a reminder and summary of some of those key findings that I just talked through. So first, in terms of mental health symptoms, we saw that the intervention group had larger reductions in anxiety symptoms, both immediately after the intervention, as well as 4 months post-intervention. For depression, those reductions in depressive symptoms weren't significant until 4 months post-intervention. In terms of those intermediate factors related to family planning use, compared to the control group, we saw that the intervention group had increased partner communication as well as reproductive agency immediately after the intervention, but that those changes weren't sustained, that those things dropped back down 4 months after the intervention. And then finally, in terms of family planning use, that modern family planning use increased significantly from baseline to that longer term effect 4 months after the intervention, but there were no significant differences immediately after the intervention. We also saw that there were not significant effects on intentions to use a family planning method. And so with that, I will turn it back over to Leah, who will take us through to the implications and next steps.
Thank you so much, Zoe, for that wonderful overview of the study methods as well as the results. So before we talk about the implications, I did want to highlight a few limitations with this study. So the first is with regard to symptom severity. So one thing to note, as Zoe mentioned in the sampling frame, this study focused specifically on women with mild to moderate symptoms of depression and anxiety, and so the findings should not be used to inform interventions for women with severe depression and anxiety or other mental health conditions. And then the second is around the cluster selection. So we did select the clusters based on specific criteria that Zoe had mentioned. However, we did not sample certain communities based on accessibility. So this could mean whether they were accessible during the rainy season or their distance to the capital city and feasibility to collect the data in a day. So while most of the communities that we sampled were in rural areas of the West Gojam zone, the results might not generalize to some of those communities, those rural communities that are hardest to reach. And then the third is around the Amhara region state of emergency. So during the study period, the Ethiopian federal government declared a state of emergency in Amhara in August of 2023. And this resulted in road closures, curfews, and limited internet access. As a result, virtual data collection was required in about a third of the sample at the 4-month follow-up period. The results were stratified and compared across these two different data collection modalities, and no significant changes were observed. But this should be considered when interpreting the changes from baseline to follow-up or endline to follow-up, as participants may have had limited access to health services or elevated anxiety and depression during this time. And so with the results that Zoe just shared, we did see that in the control group and in the intervention group, symptoms of anxiety did elevate from endline to follow-up. And so this could be related to that state of emergency. That's another hypothesis that we were exploring. So these are just a couple limitations to keep in mind as we discuss the implications. And so now I'll talk about a few emerging recommendations that we had come up with for scale and suggestions for future work. So these recommendations were developed following the analysis of findings, but we further refined them and informed them from dissemination workshops that were hosted in Ethiopia. And these included stakeholders from the family planning space as well as mental health space. So this first recommendation is related to including mental health in community health programs and health system strengthening efforts. So as mentioned earlier, there's insufficient access to mental health interventions and a lack of professional health seeking relative to the prevalence of depression and anxiety among pregnant and postpartum women. So simple solutions like CBT or the Mother's Time intervention, which we've been able to show can be easily integrated within family planning or maternal health services, especially at the community level, provide that opportunity to close some of these mental health treatment gaps and improve awareness of mental health issues. In Ethiopia specifically, Ethiopia has a robust community health infrastructure as well as a national mental health strategy. And so the Ministry of Health, in collaboration with the WHO, has prioritized the utilization of specifically this mental health gap action program to train primary care workers on various mental health services. And so this, coupled with the robust community health infrastructure, provides a very supportive environment for continuing to scale this intervention. However, some things to consider around scale and integration into community health systems. In order to effectively integrate mental health services at the community level, a health system strengthening approach is needed to maintain balance in community health worker workload and address any access or capacity gaps in the primary healthcare systems that surround them or and are connected to them. We see this specifically around referrals or addressing some of those more severe conditions that we weren't able to address through this intervention. The second recommendation here is exploring the integration of mental health into family planning and MNCH programming. So as many of you are likely aware, there's a growing evidence that suggests that interventions which integrate mental health care into routine MNCH care can be effective in low and middle income countries, though adoption of some of these policies that support this approach remain scarce. So globally, about 85% of women receive antenatal care at least once. And so this provides an opportunity to offer more comprehensive and holistic maternity care that includes a consideration of mental health, either an assessment or management during this time. And so during this study, the research assistants were trained to use a simple PHQ-9 and GAD-7 screening tool, which Zoe had mentioned. And this allowed the researchers to identify women who were experiencing depression and anxiety symptoms. During the dissemination workshops in Ethiopia, we had talked about potentially in future iterations of this intervention exploring the potential for training HEWs to administer these tools, which would allow for screening of both depression and anxiety during routine ANC care or during a mother's postpartum wellness visit. In terms of family planning, further integration of this intervention beyond the postpartum period is another area that we had talked about as an opportunity, as this could raise awareness around mental health conditions and support decision-making around family planning intentions that are consistent throughout a woman's reproductive life cycle. And then the third recommendation is around exploring intersections between mental health and SRHR behaviors and norms. So as we talked about earlier, a lot of these norms that we were looking at often intersect other health areas like HIV or maternal health, in addition to family planning and mental health. So considering how this intervention can address a broader range of norms that can also address a broader range of women's health needs is another area to continue exploring. One thing that we talked about in some of the dissemination workshops was the use of other community-based partners like religious champions or other community agents to address specific factors like religion and other unique population characteristics that could be impacting use to family planning or impacting mental health. So this was one area that we talked about. Another area that we talked about was exploring how this intervention could be used in post-conflict settings or for people who are displaced by conflict. While postpartum women represent a critical group requiring family planning and mental health assistance, one priority population for the Ministry of Health as well as the stakeholders in Amhara is people affected or displaced by conflict, as they are experiencing regular disruptions to essential health services. So being able to offer an intervention like this could be really valuable in those types of settings or populations. And then the last one is around tailoring and scaling CBT more broadly. So through some of these other recommendations, we've touched on various avenues for scale, like integrating it within community health systems or within family planning or MNCH care. But something that's unique about these results is the fact that they used a story-based CBT intervention to facilitate understanding of how women act on their own family planning intentions and or mental health struggles, which we saw ultimately facilitates behavior change. And so a lot of SBC practitioners, this kind of theory of change is seen in a lot of SBC work, but this is something to continue exploring and scaling this type of story-based intervention. And then more recent work in this space has been looking at the application of entertainment education via widely accessible and frequently used digital tools such as smartphones or social media platforms. And so digital interventions are another area in which we could potentially scale this intervention and maybe take the stories and bring them to life in animated forms and be able to leverage some of the power of that storytelling in another way. And for the Thinking Healthy intervention that this intervention was adapted from, they have developed a protocol that's testing a technology-assisted version of this program. So we do think that this digital avenue is another area that we could explore in future scale of this intervention. So before we turn it over to the Q&A, I did want to just note a few acknowledgements that Lynn had mentioned earlier in the presentation. So firstly, we really wanted to thank the Ethiopian Federal Ministry of Health for their contributions to the study design, as well as their inputs on some of the results and findings. We also wanted to thank the team of mental health specialists at Njabara University, so to Sarah and his team, for their expertise in adapting and implementing the Mother's Time intervention. We also wanted to acknowledge our team at Deep Dive Consulting, based in Ethiopia, for their coordination and implementation of the data collection activities. And then we really wanted to thank the study participants as well as the Warda Health Office officials and health workers in Amhara region for delivering Mother's Time. And then lastly, we wanted to thank the U.S. Agency for International Development for funding this work. So with that, I'll turn it over to Lynn. I know she's been tracking some of the questions that have been coming in, and we'll be able to answer some of those.
Excellent. Thank you so much to Leah, to Sarah, and to Zoe for the great presentations. And also just wanted to call out, I see Sarah Burgess is on the line and want to give her a huge kudos and thanks since she was involved in this work from its inception. I see Guda's on the line from the USAID mission in Ethiopia, who has been incredibly supportive, along with Stephanie Levy from USAID Washington and Angie Brazington. We started this work some years ago, and it's just really, we appreciate everyone who stuck with us along the way. I see in the Q&A that Jessica and others have been answering most of the questions, but we still have 15 minutes left to answer a few more. So I'm going to dive right in. And to Sarah, I'm going to give the first one to you, please. Krista had asked some questions around integration of the mental health care within other priorities of the Federal Ministry of Health. And you had answered to a certain extent already. She wanted to maybe dive in a little bit more, for example, for MNCH and family planning programs or other health development army priorities, sort of getting back to that context of Ethiopia in the early part of the presentation. Is there any more that you want to say about that in particular? I know we've had disseminations with colleagues in Ethiopia already, but just wanted to give you an opportunity to speak to that one more time if you wish. Sarah, are you able to unmute?
Hello, hello.
Hi.
Hello, Lynn. I lost you. Sorry, Lynn.
That's okay. We're just thrilled your connection has stayed this long. So Krista had asked a question sort of in the Q&A around appreciating the cluster design for real world implementation, and asked us around, what is the potential future work around integration with existing projects within the Federal Ministry of Health. And really thinking about, integration of mental health care within other priorities, for example, MNCH and family planning, or other programs through the Health Development Army. Can you say any more about sort of conversations or the way forward with the Federal Ministry of Health around potential for taking this work more broadly?
Yeah, great. That looks important question, Lynn. Yep, we're actually having a thought on during at the design stage regarding about the scalability of the intervention. We chose the health extension workers, Ethiopian community health workers, because in Ethiopia, there is at the grassroots level, these health extension workers are actually, they do have what's known as the mental health package, and they are managing that package. Actually, they are supposed to provide some activities and conduct some activities with respect to the mental health of the perinatal women as well as the members of the general public, actually. And besides that, the strategy also aims to integrate these types of interventions within the primary healthcare system. And we think that this intervention is actually a good, it provides a good opportunity for the Federal Ministry of Health to integrate using the existing manpower or human power, yeah. Thank you.
Great, thanks to Sarah. Afifa has a question, and I'm not sure Zoe or Leah who wants to take it. But her question is around, the follow-up results for reproductive agency and partner communication are interesting. What value do you think there would be in adding an activity for partners addressing family planning information, couple communication, role of the partner in supporting new mothers, and dare I say mental health? And we did debate this a lot. So I don't know if Leah or Zoe, who wants to take this one?
I can jump in, and then Leah, if you have anything else you want to add, feel free. Afiva, I love that suggestion. I think it speaks to the fact that there are other sort of interpersonal factors that affect some of these intermediate things that affect family planning use. So the role of the partner, the role of the context of the household. I think we had another question or comment around sort of the role of gender norms as well. And so I think that would be a great suggestion. Of course, that would shift sort of the design of the intervention and thinking through sort of how it's implemented on the ground. But I think that could be a nice complement and something that we could test potentially as an add-on for sure. I don't know, Leah, do you have other thoughts?
No, that's great, Zoe. And I think that's a really important point. I think we see also like in the HIV space, there's a lot of partner-based communication tools. I know that I've worked specifically on some interventions where we've worked with engaging male partners around HIV self-testing, and the engagement of male partners can end up actually creating better outcomes for the woman. And so I think that training component of the males and also considering their mental health is a really important avenue to continue exploring. So thank you for elevating that. I think that's something we should continue to think about.
Absolutely. Thanks for the question, Afifa. And one of the things that we were debating in the intervention design is how to balance something that is sort of in-depth enough to have impact, but not too complicated or cumbersome so as not to be feasible to implement and scale. So, this idea of being able to, develop something strong enough to then scale more broadly was really front and center in designing from the beginning. I'm going to move to the next question here from Rose, and this one is fairly straightforward. Oh, nope, it's just been answered. We have Jessica is flying through, as is Zoe. We have 18 questions answered already in the chat, but I wonder if maybe some of you might want to elevate a couple of them for discussion. Yeah, let's see here. Zoe, do you want to speak to a couple of the questions that you responded to? I don't know if there's one in particular that you want to get into a little bit further, but there's such rich content in the Q&A that I'll defer to you on that.
One that I was really thankful for was a question from Lisa about the intersections between mental health and reproductive agency and sort of how we see more sustained effects on depression symptoms, but we don't see that with reproductive agency, and how and why we might be seeing that. And I think that's a really important question. We would have expected, sort of our hypothesis would be that those would be negatively associated. So sort of more reproductive agency, fewer depressive symptoms. And so the fact that we're not seeing that sustained effect of reproductive agency is a question that we're still trying to understand why we're not seeing that. One sort of thing may be that reproductive agency is sort of how we measured it, that role in decision-making around pregnancy prevention, similar to partner communication, may be something that changes a bit more in comparison to depressive symptoms, maybe is a little bit less stable. And so that might fluctuate sort of across different questions or across different questionnaires. But it's definitely something that sort of looking at that interaction might be a way for us to move forward. So just flagging that for our team, a little further analysis. But then also just to speak to the fact that in all of the models presented, they were multivariate, and we did in some of those adjust for reproductive agency, even in the mental health outcomes, and still saw that prolonged effect. So there wasn't really evidence of confounding, at least of mental health and reproductive agency, but definitely an interaction that we want to explore further.
Thank you. And I see Tessera has responded to a question that sort of is connected to that from Marta around the idea that, reproductive agency and ability to communicate with partner signals that individual changes are not enough. you know, and I think this is really important. We're talking about social and behavioral change, not just individual behavioral change, and sort of the interaction between the women in the group, but the interaction between the women and their partners, all of these sort of social norms, gender norms, you know, play a role in the outcomes that we're seeing here. We have 5 minutes left. I think, you know, since so many of these have been answered in the Q&A, and thanks to the team for being so on it and answering all these already, let's move to the next slide before we have our final poll question. And this is something, you know, few people have touched on it already, but we're really interested in hearing from you. You know, what do you see as some of the potential for integration into community health programs or primary healthcare systems writ large? How can mental health be better embedded into primary healthcare or community health worker system strengthening efforts? Secondly, potential use for digital to scale. You know, this is one idea that we had. You know, do you think that future testing or scale of these types of mental health interventions might work by using digital through phones or otherwise? And then really, you know, the funding for this work came from USAID Washington Central funding around family planning and reproductive health. And there are opportunities likely to embed similar interventions like Mother's Time within maternal, newborn, and child health programming and otherwise. So really curious if you all have ideas or thoughts around that. And again, feel free to mention them in the chat. Yes, Krista, tying interventions to well-funded programs like family planning, MNCH, and HIV, that certainly helps. And there are surely other ways that the learning from this exercise could be scaled. So we will absolutely be sharing with you the recording of the presentation. We'll be sharing the slide deck as well. And we are truly grateful that you have joined us today. Please stay connected. You know, we've added the links to the technical brief that is currently on the Breakthrough Action website. We've also added the link to the Mother's Time actual tool so that you can download that, adapt it, feel free to use it. We welcome that. And we also have a peer review journal, a manuscript in process, and that should be going through peer review soon. So we'll get this in the published literature as well, but really appreciate. And thanks, Jessica, for reposting the link to the technical brief. Really want to appreciate all of our presenters today and all of you for staying on for the hour. We're really grateful. So thank you again, and we will wrap up in these final 3 minutes. If you have any final comments or questions, please add them in the chat or the Q&A function. And again, we'll be circulating everything afterwards. And thank you, Marcella. Our final poll for the day, if you could please fill out this very short questionnaire, our post-webinar survey, we'd be truly grateful. Thank you again, everyone.